Hello. Hello. Today we'll be going over hospital-acquired pneumonia. We are Group 6, and my name is Lauren Larkins. Included in this group is myself, Kelsey Browning, Janice Jones, Monica Vidal, and Avery Wills. Hello, this is Lauren Larkins, and I did overview of quality, safety measures, and organizations slide. Number 1. Dashboards are a type of health information technology that use data visualization techniques to support clinicians and managers in viewing and exploring data on processes and outcome of care. A quality dashboard is used to monitor the quality of care and explore ways we can improve where there is errors. Number 2. According to the U.S. Department of Human and Health Services, quality indicators are standardized, evidence-based measures of healthcare quality that can be used with readily available hospital and patient administrative data to measure and track clinical performance and outcomes. Number 3, organization level. Financial performance is necessary to include in a nursing services dashboard to understand the relationship between cost and quality. For example, a hospital with the ability to invest in facilities, technology, and processes can be expected to have better patient outcomes. This is true if we think of a rural hospital compared to a hospital in a big city such as Atlanta, for example. When there is advancement of technology to help the patient, they are going to have a way better outcome than in a rural setting who doesn't have the equipment they need to do certain type of procedures. Unit level. Unit-specific dashboards are being used to monitor performance and drive quality improvement efforts from the perspective of nurses and unit management. In other words, through this dashboard, frontline nurses and managers on a unit can use the dashboard to identify and improve quality care specific to their unit, such as cardiac ICU, surgical ICU, ER, labor and delivery, for examples. Hello, my name is Lauren Larkins, and we're on slide 3, and we're continuing the title of Overview of Quality Safety Measures in Organization. Number 4, the data is collected by documentation, reporting, support tools that all goes into the electronic health record, or EHR. Collecting data for the dashboard also depends on the type of dashboard that includes the type of database integration, visual properties, purpose, time focus, and a type of process monitored.
This is Kelsey Browning, and I did the slide about individual indicators. For question number 1, I analyzed the data for the quarters and overall. For quarter number 1, 3 incidents occurred. For quarter 2, 2 incidents occurred. For quarter 3, 4 incidents occurred. For quarter 4, 4 incidents occurred. For all the quarters, the target goal was 0 incidents, but as you can see, this did not happen. For question number 2, the reason why we are measuring this indicator is to determine the number of occurrences of hospital-acquired pneumonia so we can reduce the chances of it occurring. Measuring and reporting outcome data is fundamental for healthcare systems to drive for improvement. The information provided by dashboards allow population health quality data of their patient panel and to use that information to identify care gaps. For question number 3, hospital-acquired pneumonia is a problem in the healthcare setting because pneumonia that starts in the hospital tends to be more serious. This is due to people in the hospital already being very sick and being unable to fight off additional germs, along with the issue of the types of germs that are present in the hospital that are often more dangerous and more resistant to treatment than those present outside in the community. Hospital-acquired pneumonia also leads to additional illnesses that make it even additionally harder for a patient to recover. For example, out of 119,075 cases of non-ventilator associated hospital-acquired pneumonia, 36.3% of the patients developed sepsis. This is Kelsey Browning, and I will be continuing the individual indicator slide. For question number 4, CMS measures and reimbursements are an issue. Due to hospital-acquired pneumonia being preventable, Insurance such as Medicare, Medicaid will not pay for the medical expenses related to the infection, and the hospital will have to cover the costs and any additional illnesses that arise related to the infection. CMS created a reimbursement program for hospital-acquired conditions that will pay hospitals to help reduce the incidence and to report the occurrences. Hospitals with a total hospital-acquired condition score greater than the 75th percentile of total HAC scores, example, the worst performing quartile, will be subject to 1% payment reduction, meaning they will only reduce the cost by 1%. Although CMS does offer a small amount of reimbursement, the issue at hand is the overall occurrence of hospital-acquired pneumonia due to it being preventable. CMS measures are aimed more towards reducing the occurrence of hospital-acquired pneumonia and holding the hospital accountable for their preventable mistakes instead of outcome-based funding.
Okay, this is Janice Jones. Doing the slide on investigating the problem. Some of the therapeutic interventions that should be in place during an individual's hospital stay to prevent hospital-acquired pneumonia, which is known as HAP, are aiding or providing oral care, raising the head of bed to 30 to 45 degrees, getting the patient up and mobile as soon as possible, promoting the use of an incentive spirometry, and having the patient practice deep breathing, coughing exercises, and rolling them over periodically. The lack of doing these things is what's known as miscare, and that's where the problem lies with why we have so much HAP. So this study found that oral care greater than 2 times was not documented for 59% of patients. 36 did not elevate the bed to 30 to 45 degrees. 29% patients that were allowed to get up and move, they were only out of bed twice in a 24-hour period, and 55% were out of bed less than 2 times. 81% was not documented for incentive spirometry, which I find absolutely crazy, and nor cough and deep breathing exercises was 67% in the 24-hour before pneumonia diagnosis. So the whole point in this study was to look at the 24 hours before the patient got diagnosed with HAP. So they were looking at what led this patient to have this diagnosis. And the prevalence of this miscarriage is correlated to the high occurrence of HAP. Okay, next slide. Bacteria found in dental plaques have been found to be a causative agent in HAP in several studies, with a reduction in pneumonia incidence following institution of an oral care regimen for patients. Oral care is a major nursing intervention that needs to be done in order to prevent all forms of pneumonia, and that's including aspiration pneumonia. Oral care is typically done for patients on a ventilator, but not so much for patients that are not on a ventilator in the ICU. This study reviewed 115 patients diagnosed with non-ventilator hospital-acquired pneumonia, and 73% didn't receive oral care each shift. A protocol was put in place for all patients in the ICU to receive oral care 4 times within 24 hours. They end up getting great outcomes by this. The nurses and the other healthcare workers did comply with this. So the oral frequency, at least once a shift, increased from 27% to 80%. Oral care for non-ventilator patients in the ICU increased by 800%, and the rate of non-ventilator HAP per 1,000 patients decreased by 35%, and the hospital amazingly saved $1.6 million. So they found this problem here, and the high cases in HAP was the lack of oral care, which it may seem a lot to make sure each patient in the ICU to receive oral care once per shift. But I know at JCMC there's just like 5 people in one ICU room, and with the amount of money they saved this was over a 12-month period, and the decrease in patients, I think it'd be beneficial.
My name is Monica Vidal. My name is Monica Vidal, and I will be addressing the deficits involving hospital-acquired pneumonia. This led us to look into interventions that may mitigate the occurrence of hospital-acquired pneumonia and in turn lessen the mortality rate. Best practice interventions are intended to decrease the risk of aspiration and reduce bacterial colonization. The Centers for Disease Control and Prevention has set forth standardized guidelines for preventing hospital-acquired pneumonia. They include staff education and involvement in infection prevention, the surveillance for pneumonia in high-risk patients, sterilization, disinfection and maintenance of equipment and devices, upholding standards of hygiene precautions, proper aseptic care of patients with tracheostomy, the use of only sterile fluid to remove secretions from the suction catheter if the catheter is to be used for re-entry, pneumococcal vaccinations, precautions for preventing aspirations, and turning and rotational therapy. Different hospitals have set forth their different prevention controls. A study done by Kaiser Permanente of Northern California have found significant reduction in hospital-acquired pneumonia when they implement a prevention bundle, and also in their employment of skillful leadership in order to properly execute such interventions. These interventions are set in place and improve performance measures. Some of them include aggressive mobilization, upright posture for meals, swallowing evaluation before feeding, sedation restriction, elevated head of the bed, oral care, and feeding tube care. These measures are mostly concentrated on basic nursing care, which has been shown to be effective in the prevention of these type of infections.
This is Avery Wills, and I'm going to be reading the slide application to EHR client. For number one, I found that while the application of electronic health record system promises a number of substantial benefits, including better care and decreased healthcare costs, serious unintended consequences from this implementation of these systems have emerged. Poor EHR system design and improper use can cause EHR-related errors that jeopardize the integrity of the information in the EHR, which leads to errors that then endanger patient safety or decrease the quality of care. The impact of unintended consequences of the use of the EHR systems on the quality of care and promised solutions to address EHR-related errors. For number two, I found that the nursing process must be supported by EHRs through integration of best care practices, seamless workflows that display the right tools, evidence-based content, and information at the right time for the optimal clinical decision-making. The design of the EHR documentation must attain a balance that ensures the capture of nursing's impact on safety, quality, as well as health, reliable care, patient engagement, and satisfaction, as well as minimizing death by data entry.
This is Kelsey Browning, and I did question number one on the role of the BSN nurse and leadership skills slide. For number one, nurses can play a significant role in help preventing hospital-acquired pneumonia from occurring. Nurses need to lead the way in the design and implementation of policies that allow for adequate time, proper oral care supplies, ease of access